Dear friends, in chapter 1, we saw that an idiopathic epithelial membrane was in fact a simple mixture of posterior haloid and gliosis, essentially astrocytic gliosis, in contact with the ILM. We will now see why there is this astrocytic proliferation, what is the initiator of this epithelial membrane, and especially how the removal of the ILM can exert such a beneficial effect. Astrocytic gliosis is, as we have seen, the only component of the idiopathic membrane that is not found in a normal state. Let's see why it appears. In neuropathology, astrocytic gliosis is found in case of ischemia. Chronic ischemia of the mouse brain causes a reactive astrocytic gliosis that would prevent neuronal death. In contrast, a reduction in GFAP in perivascular astrocytes is associated with an increase in barrier breakdown and rapid cell death. It is therefore a protective mechanism against ischemia. For the idiopathic epithelial membrane, many clinical arguments support the hypothesis that, as in the central nervous system, ischemia is the initiator of this retinal reaction. If we observe the retina around an idiopathic membrane, we can almost always see vascular abnormalities such as crossing zone or vascular constrictions. The edema accompanying the membrane is a sign of ischemia. Frank Becquet proved that in most of idiopathic membrane, the multifocal ERG shows a P1 implicit time delay normally found in ischemic retinal disease. Finally, Zofia Michalewska showed that in swept source OCT, idiopathic membrane are accompanied by an increase in choroidal thickness, sign of retinal ischemia. Thus, although other mechanisms such as certain neurodegenerative or inflammatory disorders may also cause astrocytic reaction gliosis, we believe that chronic ischemia is the most likely hypothesis. This astrocytic proliferation, which develops horizontally at the level of the inner layers of the retina, seems to protect these internal layers from the ischemic consequences. In fact, in most cases, the cystoid edema develop into the outer layers and does not invade these inner layers. There are some cases, however, where ischemia occurs more abruptly and gliosis proliferation does not have the time to develop, where the edema can be organized into microcystic edema and occupy the entire retina. Thus, as it is the case in neuropathology, this astrocytic gliosis appears really to be a protective mechanism against ischemia. But then a question immediately comes to mind. How does removing a protective structure at the same time as the ILM can have a beneficial effect on visual function? In other words, the removal of ILM, how does it work? To explain it to you, I will voluntarily be very simplistic. If you want to know more, refer to the articles that Claude Baucher will publish in the coming weeks. Claude is, in this field, a real sink of science, reading all the microbiology and neuroscience articles on gliosis and reaction mechanisms, microvilli and transmembrane transfer, to check if what Yvette and I had found was consistent with the neuroscience data or simply pure intuition. I do not think I betray her thinking by saying that what I'm going to explain schematically is entirely in line with the current neurobiological data. To understand how works the ILM peeling, we must first remember the two things that we have just seen. The first is that idiopathic epidermal membrane is not a disease, and the second is that astrocytic gliosis is a protective mechanism against ischemia. It is not therefore in removing anything harmful that we will treat the patient. It is by provoking a retinal reaction. In fact, the retina, like the central nervous system, reacts spontaneously to aggressions. The first type of reaction, as we have seen, is astrocytic gliosis in reaction to ischemia. The problem is that in the retina, astrocytes are only located in the inner layer, since to fulfill their nerve nutrition function, they have one foot on the vessel and one foot on the axon. This is also why, by removing the ILM, microhemorrhages are created here and there because of this vascular anchorage of astrocytes. Astrocytic gliosis, that is to say the multiplication and the charge by GFAP fibrils of astrocytes, can only protect the inner layers close to the ILM, which is not sufficient to protect the entire retina from edema, as we have seen. But my wife has shown that there are cases where, despite ischemia, there is no edema in the outer layers because, in addition to astrocytic gliosis, there is a Müller cells gliosis extended perpendicularly from the ILM to the ELM and protecting this time the entire retinal thickness. These cases are each time cases where ischemia is associated with retinal detachment. This vertical gliosis, perpendicular to the retinal surface, is present whenever there is a retinal detachment. It is similar to what is called in neuropathology the radial glia, which is a transverse protective mechanism that protects the nervous tissue from the traumatic damage. When the spinal cord of a rat is traumatized, the radial glia settles down perpendicular to the surface of the spinal cord to repair the damage. As Müller cells are responsible for retinal homeostasis, we understand that a trauma can make them react. Here are two examples that perfectly illustrate this discovery. Two right eyes, enucleated for malignant melanoma, compressing both the optic nerve and those causing ischemic lesions. In the example on the left, the macula is not detached, as demonstrated by the presence of RP cells in contact with the neuroepithelium. the retina is invaded by a large macular edema barely contained by an astrocytic gliosis at the inner edges. There is no muller cell gliosis. In the example on the right, the macula is this time detached by a subretinal exudate. Astrocytic gliosis has been associated with muller cell gliosis, occupying the entire retina thickness and preventing any edema from becoming established. So let's see a little more in detail what happens in retinal detachment. A trauma occurs at the outer pole of the muller cell with a tearing of the fibers which, extending the muller cells, surround themselves around the RP cells. This trauma signal, added to the tissue distortion generating apoptosis, leads very quickly to EGFR stimulation. Yvette and Claude Bauchet have shown that the creation of a retinal detachment in pigs immediately leads to a very violent activation of EGFR throughout the thickness of the retina, followed shortly after by a radial muller cell gliosis. In fact, this activation of the EGFR is the starting point for a cascade of events and cellular reactions aimed at protecting the cells, stimulating tissue regeneration, and repairing the damage. This explains why, despite ischemia, there is so little damage when a retinal detachment is operated within 15 days. Among this cell reaction cascade, we can mention the activation of the RPGF, responsible for the multiplication of the pigment epithelium released into the vitreous, which explains the PVR, and anti-VEGF effect, which explains the fact that the retinal new vessels seen in low progression detachments appear only after 6 months after EGFR extension. The production of retinal and ciliary progenitor cells, the production of growth factor and PEDF, the production of pro-inflammatory factors, and especially the production of radial gliosis, a true neuroprotective and repairing process since GFAP has synaptogenesis properties. We thus see the wealth of protecting and repairing mechanisms that the retina puts in place in case of trauma at the outer pole of the muller cells. But let's go back to the internal limiting membrane. Admittedly, the ILM peeling is one of the best ways to be sure that you have removed all adherent hyoid fibers. This is true, and this explains the disappearance of metamorphopsia after ILM peeling. But in no way can this explain this much greater functional improvement compared to cases where a simple membrane peeling has been performed. There must be, therefore, in addition, a repairing mechanism. This is what Wolf showed by proving that the ILM removal is always accompanied by a tearing of the muller cell hand feet and therefore by a trauma of these cells. It is therefore normal to think that the trauma at the level of their inner pole caused by the peeling has the same consequences as that caused by the retinal detachment at their outer pole. Certainly, ILM peeling removes the astrocytic proliferation, a repair mechanism protecting the internal 10% of the retinal thickness, but above all, it induces a Müller cell trauma causing a cascade of repair reaction and especially a Müller cell gliosis, protecting 100% of the retinal thickness. In fact, by removing the ILM, the body's spontaneous restorative response to ischemia is increased by using the much greater repairing power of the trauma response. However, this does not prevent the retina from continuing to respond to ischemia, as can be confirmed by the small retinal reflections that can be seen 1 month after ILM peeling, indicating that astrocytic reproliferation has occurred even though there is no longer any hyaloid fibers or ILM. Having no anatomical pieces removed after ILM peeling, we can only defend this assumption based on the fact that the same causes produce the same effects. But if we admit that, everything becomes clear. The ILM peeling is not the removal of a pathological process, but on the contrary, the induction, the stimulation of a larger retinal reaction in order to repair the ischemic macular damage. You can now understand why, since 1989 for epiretinal membrane, 1992 for macular hole, and 2000 for pure edema, I introduced and defended this concept of systematic ILM peeling. Some have taught me in the introduction of this concept, continuing to treat some vitreomacular interface syndrome, epiretinal membrane, vitreomacular traction syndrome, macular hole stage 1 or 2, etc., without removing the ILM for two scientific reasons, besides other reasons. The first reason is that it is proved that ILM peeling causes electrical alteration of the retina, with lesions visible in the multifocal ERG. But that is precisely why it works, because it creates a microtrauma. If there was an enzyme capable of removing all hyaloid fibers without affecting the ILM, it could treat metamorphopsia but would have no effect on repairing the damages caused by ischemia and consequently on visual function. If we wanted a treatment having the effectiveness of ILM peeling without removing it surgically, we would have to imagine an EGFR activator or, in the extreme, create a retinal detachment. The second reason of these advocates of respect of the ILM is that visual improvements can be obtained either without surgery when the PVD is done spontaneously, or after a simple injection of air, or after removal of the membrane alone. They simply forget that when astrocytic proliferation has penetrated the hyaloid fibers, a simple PVD or a simple membrane removal leads in many cases, up to 75% of cases according to some authors, the unintentional tearing of islands with tearing of the Müller cell and feet. If we could formally compare the visual results of the cases where the ILM remained perfectly intact with those where it was widely removed, we would certainly see that the two populations are not comparable. So here is our explanation on how the ILM peeling works. So if, as we have seen previously, the only anatomical difference between the edema and the idiopathic membrane resides on the presence or the absence of the complex post-hyaloid astrocytic proliferation, cannot we imagine that this cascade of restorative reactions induced by ILM peeling may have the same beneficial effect in pure edema? This is what we will see in the next chapter.